Hello, this is Dr. DeShavo back with you for part 4 of chapter 12, musculoskeletal function. And I'm crying a little bit because this is our last one for musculoskeletal. I do enjoy teaching these. They are fun. I enjoy teaching it all, to be honest with you. So let's get right into it. An osteoarthritis is just your wear and tear arthritis that happens to, unfortunately, so many people. And it happens for a variety of reasons. It could just be that you have a little bit of a short leg, or you've sat improperly, or you walk a little funny, or you did athletics. As good as athletics are for us, it does cause wear and tear on the body. And what happens is the ends of those long bones where we have that articular cartilage or that hyaline cartilage starts to wear away. And when that cartilage wears away, you can actually get a responsive bony overgrowth. Whenever our bones have abnormal stress put on them, they're going to deposit bone in that area. So after the cartilage becomes rough and worn, the bone will deposit extra bony overgrowth there, and we also start to lose, or I should say at the same time, the synovium or the synovial fluid that's in that joint space. It's kind of a triple whammy. So if we're losing that synovium or synovial fluid in the joint space, we can't feed and nourish the cartilage, so that degenerates it even further. You get what's called subchondral bone. It sounds like a big word, but think about it. Chondro always means cartilage. Sub means under. So it's just the area that's underneath that normal cartilage in the ends of long bones. And don't forget, when we're talking about the ends of long bones, we're going to be talking about movable synovial joints. So that subchondral bone on the ends of the joints becomes exposed, it becomes damaged then, and you get what's called subchondral sclerosis. All that means is, if we're looking at the end of the femur, and we lose the cartilage on the end of the femur in that femoral hip joint, because this bone is now exposed, we'll actually deposit excess bone here, and that's your body's attempt to stabilize that damaged area. In addition to getting the subchondral, which means underneath the area where the cartilage was, sclerosis, which means basically a hardening, you'll get osteophytes. Bunch of new words here, huh? Those osteophytes are simply bone spurs. So you'll start to see, and I'm over-exaggerating because it's small, these outgrowths of bone spurs, and it's trying to stabilize this now unstable and damaged joint. The other thing that'll be happening in this joint space, don't forget, is going to be inflammation, because the body senses that there's abnormal stresses on it, and it'll create an inflammatory response to fight off what that abnormal stress is. Now, kind of a bummer, osteophytes and these cartilaginous pieces can actually break off and get into the synovial cavity. That's where you get that clicking or popping, especially in somebody that can move their joint to a certain point and then they hear a pop and then they can move it fine. It's because these little pieces are floating around that synovial cavity getting in the way. Usually with osteoarthritis, it's one-sided or unilateral, as opposed to, say, rheumatoid, which will be bilateral, which means both sides. So we spoke about most of this. The joint space will narrow because we lose that synovial fluid in that movable joint. You get joint instability, stiffness, and pain. So we all know this. Knees, hips, shoulders, spine, right? You're like, check, check, check. Because of wear and tear with your jobs, I'm sure, lifting, pushing, and pulling. So its cause is not inflammation, but you do get inflammation because you get irritation in the body's response to damage in that area. We get older, we have one other choice, right? So advanced age is going to be one of the main causes for osteoarthritis, but we can also get overuse, especially in extreme athletics. Gymnastics always pops into mind for me. Dance is another one where they're overusing their joints at a young age. Additionally, they're hyper flexible. And we always think of flexibility as a good thing. It is, to a point. If they become hyper flexible, your joints can become unstable. Rheumatoid arthritis is different. I think some people, especially older people, will say, I have the rheumatoid, and they mean osteoarthritis. So rheumatoid is an actual autoimmune condition. And in these patients, it's more females. I've actually seen a few cases for males, just as a sidebar. And with these patients, they have some sort of autoimmune disease in which their body is not recognizing their joints as their own. Unfortunately, there's no cure for it. There's very good medicines for it, though, that help to curb it. So this is inflammation gone awry that affects these synovial joints. We're going to walk through the different steps that happen to them. So they may have remissions and exacerbations, and then it progressively gets worse every time until finally the joints get damaged and they start to get very stereotypical signs. I'll show them to you. It'll start with an acute inflammatory episode, and then that episode, as it gets cumulative, causes damage to the joint. And that pathogenesis, genesis always means creation of, the creation of this disease over the steps is going to be, and I have a picture on the next slide, synovitis, which is going to be inflammation of that synovial membrane and into the joint. That progresses to the point where we actually form what's called a pannus. And a pannus is going to be a thickening of that synovial membrane, which makes it look like a thick, fibrous connective tissue with some vascularity running around it. The cartilage will erode. Eventually, the joint itself will fibrose, and you'll get fibrous connective tissue forming into the joint, and that forms the framework for calcium deposits, which will make that joint ankylosed or fused together. So here's some good pictures that I found online for you, and these are the stages. So here's that nice, healthy synovial joint. Here's your synovium. Here's the cartilage on the ends of those long bones. You've got the joint capsule, which is some fibrous connective tissue, but then also some more membranous material on the inside. And then you've got tendons crossing that joint. With early progression of RA, you start to get swelling, and that's represented by the redness in there. You start to get that thickened synovial membrane and inflammation even out into the tendons. As it progresses even further, the whole area becomes inflamed and sore. You start to move into that pannus formation, which is the thickening of, I'm not sure if I pointed that out previously, the pannus is the thickening of the joint capsule and that inner synovial membrane. So that moves more towards a thick, fibrous presentation that's thickening and hardening that joint capsule. That will actually turn into fibrous connective tissue on the joint capsule and inside the joint of itself. And that can lead to an actual hardening of the joint itself, an ankylosing of the joint itself. And they get osteoporosis in that area, so they can actually get fractures into that joint space. Well, it's not a joint space anymore, but that leftover joint space. And these are all those steps that we just went through. I disagree with this. Okay, you know, me and this book respectfully disagree. It's usually going to be bilateral. You're usually going to see it in both hands. You usually see it in both wrists. I guess maybe they mean unilaterally initially. As it progresses, you're not going to have patients that have those deformed hands on one side. That's usually going to be on both sides. I would say unilaterally early, bilaterally later. There we go. That's a good compromise. right, most commonly affects the wrists, fingers, knees, feet, and ankles. You're really going to see this in the fingers, right? Is where we'll see it with patients. As a little sidebar, I'm going to throw in there C1 to C2 ligamentous instability. The reason I'm putting that in there is because as a chiropractor, this is one thing they drilled into us. And I actually had a patient I sent out for x-rays, a whole what's called Davis series, where you move them through ranges of motions, flexion, extension, whatnot. And I even told the radiologist, I'm not going to say who, so I'm not breaching any confidentiality, she has rheumatoid. I need to see the instability or the stability of C1, C2 before I crack her neck. And she indeed had it and he missed it. So just as a sidebar, if you have somebody who has rheumatoid and you send them for a flexion extension series of their cervical spine, I actually could see in neutral she was fine. When she went into flexion, there was a huge space between C1 and C2. That's where your midbrain is. I was like, I'm not cracking your neck, so a little sidebar there. Okay, so got all of these explanations except the actual explanation of contractures of the tendons. So the muscles are connected to tendons, which connect to the bones. We know that. And what happens with these patients is those tendons will get swollen, you'll get fibrotic tissue deposited into them, and we'll get contractures. And this will lead to joint deformity. I was thinking as I was looking at this, I bet this would be a fantastic board question. So boutonniere deformity versus swan neck, and you may already know this. So swan neck is when this distal, these are called interphalangeal joints, okay? So a swan neck will be the distal interphalangeal joint will be flexed, okay? So it's going to be the furthest one out. I'm just going to show you on the 4 fingers. With a boutonniere deformity, it will be the next one in, which is actually intermediate interphalangeal joint. Okay, so distal or intermediate phalangeal joints. So I think it's better to remember it by this picture. And with a swan neck, this middle one here, I'm sorry, it's middle interphalangeal joint. I'm sorry, MIP. Middle interphalangeal joint. This is proximal. Okay. So the middle one is extended with swan neck. It is flexed with boutonniere. So, and I think that's easy to remember because this looks like a little swan's neck, doesn't it? So you're going to have that distal interphalangeal joint flexed, the middle one extended. I was just thinking, you might see that on your boards. You might see it on my exam. All right. And with stuff like that, if you have trouble remembering it, I always draw them out. I put swan neck and I would draw the fingers, right? And I would remember it from that. So I'm not doing a ton of diagnoses, but I think this is a good one to know. Serum rheumatoid factor test is a good one. And joint x-rays are a good one too. I also left this on because with these arthritides and autoimmune diseases, quite often these blood tests will be intermittently positive. So I just want to throw that out from a pathophysiological standpoint. Sometimes people will have exacerbations, sometimes they'll go away. So you need to follow up with these patients, right? And make sure that they're doing okay and not starting to show actual physical signs of the disease as the serum tests may be intermittently positive. Why? Probably because they have exacerbations and remissions would be my guess. Gout. So this is another inflammatory disease. It is systemic, although it's systemic in the blood and may only affect certain joints. And what happens is that people who have gout cannot break down these purines appropriately. And normally in a patient who doesn't have gout, you can break them down and excrete them. But in these patients, they have difficulty breaking them down appropriately. They are going to have excessive amounts of uric acid in their body, leading to hyperuricemia. What this hyperuricemia does is it obviously will increase the amount of uric acid in the blood, and that uric acid will stay in the bloodstream, but it'll find its way into joints. And it likes to go to joints that are cooler. Well, it goes everywhere. It likes to deposit in joints that are cooler. So it'll travel through the body. It gets to the toes, which relatively speaking compared to your torso is cooler, and they will crystallize. And they'll crystallize generally in the big toe, at the base of the big toe, but it can go really anywhere. It can go into the hands. The next step would be the fingers. My husband, he's not a patient of mine, so I'm not breaching confidentiality, has it in his Achilles tendon. And it took us forever to figure it out because he thought he had an inflammation there. He kept icing it. Well, guess what? The ice was accumulating more crystals there, causing more pain. So that's why it likes to go into the toes and the fingers, because it's areas that are cooler. So these people can either have an overproduction or under excretion of the uric acid, but those higher levels of uric acid are the problem. So it doesn't always manifest as gout, right? Most commonly in females, they'll have intermittent symptoms with flare-ups and remissions. Just could be an inborn error in metabolism. I can tell you my husband's family all have gout. All the males have gout. So now, things that exacerbate it, though, is one thinking it's genetic, is what I'm saying. Okay? So, inborn error in metabolism. It's not definitively genetic. That's my opinion. Don't take that as word, okay? But I think for some reason in their family, they have that inborn error in metabolism. Being overweight contributes to it. Consuming alcohol, okay? Beer and spirits more than wine, and eating a diet rich in meat and seafood, which have high levels of those purines that they have difficulty excreting in their urine, which is where uric acid goes. A little bit into the feces as well. So the phases, you could have acute. So the initial phases will be acute flare-ups that'll come and go. But with patients who cannot control their levels of uric acid, either due to weight, increased alcohol intake, increased meat and seafood, or some people just are not able to metabolize it, it can lead to chronic. And we learned that chronic is generally going to be more, your book says 6 months. I've seen anywhere from 3 to 6 months. Okay. And once again, I won't test you on things that, I would make it very definitive. Okay. Patient that's had it more than a year, right? I won't get into splitting hairs like 3 or 6. So chronic can be characterized by those joint sorenesses and achiness. It, could be present most of the time. It could be, especially if you have a condition like we have on the right, it could come and go in patients with controlled gout. And quite often they have to go on medicine. They can develop these tophi. So these tophi are these obvious, gross, not disgusting, can be seen with the naked eye, presentations in or around the joints, such as we've seen here, and that can drain, and also renal calculi. So this is part of the issue with people with gout, why they're recommended to go on their medicine permanently, is so they don't develop renal calculi and also not stress the kidneys too much. So serum acid, uric acid levels, joint x-rays, I threw in there for you. So the uric acid levels will show somebody who has difficult breaking it down. They could be dumping it through their kidneys, but it could also be low in those who have underexcretion. I think for the most part, you have people that have the inability to break down the uric acid crystals or the purines appropriately and excrete it in the urine. I think you're going to be more prone to see that rather than underexcretion. Okay, ankylosing spondylitis. So this is going to be an arthritis of the spine that's very progressive. And what happens with these patients is they can actually have their joints fuse. So this is an inflammation that'll start in the spine, usually in the lower back, and the SI joints, which are the big joints between the ilium and the sacrum. And then it moves upward along the spine. One of the side effects of this is an ankylosing or a fusing. In response to the inflammation, these patients will deposit fibrous tissue which will calcify over time, fusing or ankylosing their spines. And the vertebra appears square, and you can see a calcification on x-ray on either side of the discs between the vertebrae. So the vertebral column with these patients becomes very rigid and loses a curvature because it'll fuse it, generally losing curvature in the low back and creating a flat back, and then an over exaggerated kyphosis in the thoracic spine. We had a patient who had this, and he actually was so kyphotic, which is the condition of having an increased kyphosis. He actually had to support his chin. He would walk around literally with his chin in his hand. Oh, it was so sad. Could be genetic, okay, in most cases, most commonly in males, leads to that over-exaggerated kyphosis, can actually create an osteoporosis. I left this respiratory compromise in here to talk about an endocarditis because they become so kyphotic, they actually compress their lungs and they compress their heart. And just like a patient who stays in bed too long, with the lungs have to be open and working to keep things clear, right? And these patients get such a hunched back, they compress their lung space, which decreases their ability to A, breathe, B, clear things out. Endocarditis, just because of that compression, the heart's not going to beat properly, it's compressed, they can develop inflammation in that area as well. Uveitis, I didn't realize it was one of the side effects of this inflammation. For some odd reason, it must inflame the eye, and it's inflammation of the middle eye layer, which we're going to look at the eye in the next lecture. But basically, the middle eye layer, guys, is your iris and your pupil, and then the layer that actually continues back into the eye that provides a layer of blood that is in the eye, that provides blood to the eye so it can be healthy. So uveitis is going to be inflammation of that middle layer. This may exacerbate and remit as well. In this next picture, you can see that lumbar curve, that nice, S-shaped indentation can actually be lost with ankylosing, and it'll ankylose in a straight fashion rather than that slight curve of the low back. So that, my friends, brings us to a little let's practice. I'm going to pop through these. If you need to pause the tape, go ahead and do so. So looking at this first one, and just to give you some reference, right is normal. And this will be a lumbosacral spine. So that's the lumbar spine, the 5 lower lumbars, and the sacrum. And these are the iliac crests here. So this is normal. And they're pointing to the area that, they're showing you on the left, which is abnormal. And you can see also on the normal, here are the vertebra. Here's the intervertebral disc spaces. Now, with these intervertebral disc spaces, guys, you normally can't see anything. This is why you cannot diagnose off an x-ray if there's a herniation. You could have some hints, to be honest with you, but normally you can't see them. Now, if we look over here, it's pointing to one of those intervertebral disc spaces. Look at this here. Does that look darker or whiter to you? Yep, you probably got it now. If you don't, pause the tape. This, my friends, is ankylosing spondylitis, and it'll cause that calcification around the discs that'll eventually lead to it being so hard that they aren't able to move the spine easily, and it happens in the SI joints right down at the bottom here as well. Okay, moving on. This one's going to be obvious, but I want you to pause and think for just a second about the fingers, okay? what presentation are we actually seeing in this here? Okay, this presentation is that swan neck. Okay, there's that swan neck. And you could even say they use the thumb as a boutonniere. Don't do that. Okay, I think it's confusing because you have two interphalangeal joints in your fingers. You don't in your thumb. So I would ask you, and yes, this is RA. Okay, late stage RA. I would ask you more with this one. This would be a boutonnieres. Okay, just so you know. So the other thing I want to point out here is ulnar deviation of, you don't need to get into metacarpophalangeal joints. And if you want to know, these are the metacarpals, these are the phalanges. So this is the MCP. Don't worry about it. So here you can see you get what's called ulnar deviation. So here's your ulna, here's your radius, because we know the radius goes towards the thumb. And what happens with these patients is they start to get an ulnar deviation of their fingers. I think that's a very good sign and symptom to know about RA. Now, moving on to this one. This one should be pretty easy. Oh, poor thing. Could you imagine? Swollen and inflamed joint, but we're also getting a presentation of, what is that called? That is a, if you're not ready, pause the tape, tophi with gout. Last but not least, good old-fashioned, what do you think this is? It's one-sided. It is unilateral. This side is normal. This is the femoral head in the acetabulum. You can see here there's a loss of joint space. There's subchondral sclerosing, which is a deposition of that bone. And you actually have a bone spur here, an osteophyte. You got it. This is give me just a second. Osteoarthritis. And I'll clear this in just a second. It's really taken a long time today. Sorry. There we go. Okay, so this is osteoarthritis. Unilateral, subchondral sclerosing, loss of joint space, osteophytes. Boom. Excellent. All right, muscular dystrophy. This is inherited non-inflammatory disorder. There are several different forms. There's varying degrees. Some people get it very mildly. Some people get it very aggressively. So what happens with these patients is they get inflammation because of muscle fiber loss. What they mean by non-inflammatory disorders is it is not caused by inflammation. Okay, but it'll lead to inflammation because of damage to the tissues. Now, what happens is muscle proteins become abnormal, and it can actually lead to fibrosis and fat in the tissues, muscle tissues, taking over normal muscle tissue itself. And because you get a deposition of fat and fibrous tissues rather than muscle tissues, the muscles will start to work abnormally, and that can lead to the inflammation. Now, it can also affect cardiac and smooth muscle depending on how aggressive it is. Some types are rare, some are common. Most types are inherited, usually a genetic mutation. Some can cause tremendous and aggressive decline, whereas some have minimal symptoms. Some begin in childhood, some are older. I think the most common one is going to be Duchenne. And this is going to, I could see this in genetics, affect only males as an X-linked recessive genetic presentation. So you could have obvious difficulty with voluntary movement because it can affect heart muscle. You can have cardiomyopathies. You could also have respiratory infections because, don't forget, your diaphragm is skeletal muscle. So that muscular dystrophy can also damage your diaphragm and skeletal muscle. You know, since it's made up of skeletal muscle, you can't breathe as well. You also use your intercostal muscles with respiration. That is also skeletal muscle. So one of the signs is Gower sinus. And I actually learned this as tripod sign. And both of them, so you might hear it either way. I don't know how your clinical instructors will teach it to you, but Gower sign, also known as tripod sign, is when a child can't pop right up. I mean, we all know how hyperactive kids can be. And my kids, bam, 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 around all the time. And a child with MD, one of the first signs and symptoms is instead of popping right up, they use a tripod where they will, and that you can see in the back right picture there, they have to use their hands to walk up their thighs to an upright position. Okay, so I would make note of that sign. All right, fibromyalgia is such a tricky disease, and I really think in the future they're going to find something else to diagnose this. I think there's a real true cause to this, but right now we don't know what the cause is. Okay, and this is a symptom that presents with widespread muscular pain and fatigue. Can affect muscles, tendons, surrounding tissues, generally not in the joints. There are 18 specific points that I'm going to show you on a picture. No apparent inflammation or degeneration is associated with it. It's a bit of a conundrum. So cause remains uncertain. I have a few potential causes in the next screen, but part of it may be that they have an excessive sensitivity to a neurotransmitter called substance P. And substance P actually facilitates pain signals from our sensory nerves coming into our spinal cord and brain. So for some reason, these patients may be excessively sensitive to it. It may be that whenever it's slightly released, it causes excessive pain for them. So it also may be in the brain, that the brains are excessively oversensitive to pain signals as well. Part of the problem with these patients is they may have had some sort of physical or emotional trauma, extensive sleep disturbances, metabolism changes, infections, a genetic predisposition. Yeah, guys, look at that list. We don't know. Okay, these are potential causes, but it's still, we're kind of shooting fish in a barrel and not getting them. That's not a good analogy, but you get what I'm saying. But I'm telling you, in the future, I think people are going to be like, boom, this is what fibromyalgia is from. We just haven't gotten it yet. Okay, so characterize, fatigue. You could read through all that on your own. Widespread pain. That's usually how it's diagnosed. That widespread pain with those 18 spots. But they're also fatigued, and not just like us. Like, we're tired all the time, right? No, these people are tired. Like, they can't get out of bed in the morning. They can't work. It's a very difficult disease to live with. Okay, maybe correlated with rheumatoid, SLE, ankylosing spondylitis. But this is off the record. I'm giving you my opinion. I think fibromyalgia is autoimmune. We just haven't figured out why yet, or the correlation. That's my guess. And, the reason I say that is because quite often it's linked with these other conditions. All right, so diagnosis is these 18 pressure points. They have to have tenderness on 11 or more. Widespread pain. Your physical exams can rule out other things. Treatment, gosh, is tough. I know there's some medicines that do pretty well with them. Stress reduction, regular exercise, adequate rest, and proper nutrition, which is what the treatment for everything, right? So here's your pressure points. So lower neck of the front, edge of the upper breast, and people go in and rub them like very aggressively. And they're tender on everyone, but I mean, they're really tender on people with fibromyalgia. Below side at the elbow, below side bone at the elbow, just above the knee on the inside, base of the skull, neck and shoulder. You can see upper inner shoulder, upper outer buttock, and hip bone. Okay, so it has to be 11 out of 18. Bone tumors. So, the majority are malignant. These are scary, scary things, bone tumors. They're usually secondary. Unfortunately, with breast, lung, prostate cancers, these like to spread and metastasize. And these patients will get tumors in multiple areas, but it can lead to the bone. So these rarely occur as primary tumors, but they can happen as primary tumors. And reaching back, I think the primary tumors most often will show up in children. So you never want to negate bone pain in a child. The exact cause of primary tumors is unknown. So it'll manifest as pain, right? But the other thing that is a real sign is a pathological fracture. So palpable mass, fatigue, all those signs of cancer, and also localized pain in the bone. So osteochondroma, I was sitting looking at these and thinking about how do I teach these to you guys? It's the two areas that most likely will be affected. So osteo means bone, chondroma. These are going to be tumors that will develop adjacent to the growth plates, and the growth plates will have, chondral meaning cartilage, osteo meaning bone. So these will occur often in the young, 10 and 20 years of age. Osteosarcoma begins in bone cells, but it can spread out into the muscle tissues. Osteobone, sarcoma, muscles. These will be seen in children and young adults as well. Chondrosarcoma. This will begin in cartilage, and it can spread out to bone and muscle. This tends to be in older adults. Ewing sarcoma is very aggressive. This is an unknown cause. This will happen in children. And this will be in the bone and or the surrounding soft tissue. Here's a picture of osteosarcoma. This will start in the bone and it's starting to spread out into the surrounding tissues. My friends, that brings us to the end. This was a little bit of a long lecture, but then we are done. So we have a question, and then I will see you in our next chapter. So, patient presents with a localized pain in the front of their shin. It's been present for over 2 months with no relief from any treatment. You should, A, diagnose them with fibromyalgia, send them home. B, x-ray their spine, as is most likely a pinched nerve. C, x-ray their shin to make sure it's not a tumor. D, check them for Gout sign to rule out MD. Answer it correctly. Thank you so kindly. This was a fun chapter, as always and forever. If you have any questions, please reach out. I will see you in the next chapter.